This is Emily Peters recording about bone cancers for nursing care or advanced concepts of OB-PEDS. If you look at these bones, we have Ewing sarcoma and osteosarcoma. The osteosarcoma, if you can see from this picture, is kind of along that shaft portion of the bone, and it's kind of starts around the metaphysis, which is that wider portion of the shaft right above your epithelial growth plate. And then the Ewing sarcoma, kind of, if you look at the picture, you can see how it's coming out of the bone. So it starts in the bone and then it grows out. And I'll explain that more on the slide about that. So osteosarcoma is a very common bone cancer in children, and as you can see, it's your older children, starting at around the age of 10 and going into early adulthood. Of course, you can see it before or after that. The primary sites where you will see the osteosarcoma, once again, it starts at that metaphysis of the long bones, especially in your lower extremities. But like your humerus, the tibia, the pelvis, jaw, and phalanges. More than half of the osteosarcomas are found in the femur, so that is one of the most common bones. So when this patient is coming in, we are going to hear symptoms, or the things that bring them in are that dull bone pain that has been lasting for several months. Now, if you look at the ages of when this occurs, that is also when they're having some of their growth spurts again, and therefore they may just attribute this dull bone pain to those growth spurts, but then it persists. With the pain, these kids end up developing like a limp or ending up having limited motion in the extremity, and that is sometimes what brings them in. So with osteosarcoma, we end up doing chemotherapy and then surgery. The goal of the chemotherapy is to shrink as much of that tumor as possible, and then we will go in and remove it and try to salvage the limb. However, depending on where it is and how much of that bone is involved, they may end up with amputations. So with amputations, that throws in a whole nother level of care. They are going to need to learn how to use a prosthetic and crutches or other assistive devices until that prosthetic can be fit and built for their body. Some other things we need to be aware of, just kind of think about if you were to lose a limb, how's that going to affect you? You're going to have emotional issues, you're going to have self-image issues. So we're going to get emotional support systems going for these kids, peer support groups. So we're going to try to expose them to other children with similar issues, but also try to involve them with children that don't have those issues so they can get used to being out with general populations. We are going to make sure that they have a good outcome and just help their parents understand how to treat a stump, looking for that skin breakdown, looking for any perfusion issues. So go back to your days of health assessment and think about your different assessment skills that you would use to help assess a patient's skin and movement of those extremities. And don't forget about phantom pain, and make sure that we teach these kids to recognize phantom pain, and it's not unusual. Okay, Ewing sarcoma is another common malignant tumor. If you look at the ages on this slide, it can start as young as 4 and then also go into young adulthood. This cancer, like I showed you on the picture on the first slide, you can see how it starts inside the bone. Well, it starts in the bone marrow spaces and of the femur, the tibia, the fibula, ulna, humerus. You can also see them in your vertebrae, your pelvis, your scapula, your ribs, and your skull. With this one, these kids' signs and symptoms are weakened bones that sometimes lead to fractures. So for instance, I've heard of stories of children that have just fallen and ended up with severe pain, and sure enough, it was a broken bone from just tripping over their feet. And typically that wouldn't cause a broken bone, but because of the Ewing sarcoma is weakening that bony tissue, it led to that fracture. And then we notice the abnormalities on X-ray. If it is a rounded joint, they will end up with swelling and tenderness, and that will sometimes bring the child in. These kids also have a tendency to be fatigued, have a fever, end up with weight loss and anemia, and those sometimes bring the children in as well. So with this one, our treatment of choice is starting with radiation and chemotherapy because it starts in those marrow spaces. So we want to shrink as much of the tumor as possible, and then we will go in and surgically remove what we need. By shrinking and hopefully getting to the bone marrow with our chemo and radiation therapy, that will rid the system of the sarcoma, and we hopefully won't end up needing to have major surgery or removal of the extremity. They will use bone scans, biopsies, CTs, and PET scans as well to see the extent of the tumor's growth. So like I said earlier, that intermittent pain, and then it progressively worsens and gets stronger. These kids, because it is in their bone marrow spaces, we are going to discourage active play and weight bearing, because if we keep manipulating that extremity, that could cause the tumor to metastasize and spread. You should have learned about some other cancer treatments in one of your fundamentals courses, and just kind of think of those side effects of chemotherapy and radiation therapy. I also have a few slides on those as well. Remember, we need to give honest, direct answers to these children. The older the children are, we definitely want to get them involved with their treatment plan. Even the younger kids, but of course they may not be able to make some of those decisions as easily. But those children that are older or have dealt with this for a while, they can make really good decisions for themselves because they have a different outlook on life. Don't forget, we'll use a lot of distraction and complementary therapies as well. Such as massage therapy to using our video games and different things when we're doing treatments. Don't forget about our wonderful team members of OT, PT, and because they can be very useful in these cares. Don't forget, with preparation and administration of chemotherapy, that only specialized nurses can give that, and specialized people can prepare chemotherapy. Always wonder when you are taking care of a patient with chemotherapy that we need to get rid of their body fluids and sheets and different things in specialized containers that are specific for radiation and chemotherapy, so it doesn't spread or get too here is that list of short-term and long-term complications that we will need to teach our patients about. Once again, with the radiation therapy, we will have to have some other short-term and long-term complications that we will teach our parents about. And nope, you're If you looked at both pages side by side, hopefully you have your printed out PowerPoint with you, you can see they have similar long-term effects and affect similar areas. So, for instance, you'll have the myelosuppression and the nausea and the vomiting and the immunosuppression with the chemotherapy, but also you end up with having myelosuppression with radiation therapy. Long term, it ends up affecting your immunologic systems, your endocrine, your GI and GU systems. Same with radiation therapy. You're going to also end up with cardiac dysfunction, sexual dysfunction. Not unusual for these kids to maybe even have sterilization. So that is something some of these parents might have to have conversations with their children about. Do we need to do something to allow them to have children later in life? Both radiation and chemotherapy puts these kids at high risk for developing secondary cancers later in life. So granted, these cancers could have good survival rate. However, they are at higher risk for developing something later. So that's something to make sure that the patients are aware of. If you remember with your adult patients, promoting adequate nutrition is important. Well, it's just as important in our pediatric patient, and sometimes it's a little bit more challenging. So we need to keep that good body weight and length assessment. We will determine those child's food preferences and end up allowing those favorite foods within the realms of knowing that we are immunosuppressed and neutropenic, so we may not want to have fresh fruits and veggies. So figure out alternatives to get those things in. Definitely make sure we're giving those antiemetics. We will use a lot of those increased calorie shakes and puddings, like Pediasures. We may even go to like Ensures and things like that as well. These kids, since they have a lot of trouble with nutrition, if they like to eat at 5 in the morning and they have good appetites at that time, that is when we are going to give them their biggest higher calorie meals. And it's whatever they want. So if they want macaroni and cheese at 5 in the morning, that's when we're going to give it to them because they will eat it. We will even break rules of hospitals and allow kids to have their own little like a waffle station in their room if that's their favorite food, so it's available to them when they're hungry, different things. So when we think about those cultural type of foods, we allow the parents to fudge rules and get those things readily available to those children so they will eat them when they're hungry. Not uncommon to do NG feedings with these children as well for supplemental. Some end up with G tubes as well. Don't forget to push your vitamins and mineral supplements as prescribed because of the nutritional deficiencies. If they are not able to keep fluids down, and then we will start TPN, NBN, CVN. However, you want to refer to it as that IV nutrition along with lipids, which is that fat nutrition. And don't forget about the rest of our education for these families. They're not in the hospital the whole time they're getting treatment. So we need to teach those families and those older children and the younger children on how to recognize complications, helping them learn how to keep their appointments and keep it all organized. A lot of these kids get to travel due to their treatments or miracle network type of things. So we always make sure that the parents have access to the most up-to-date records and carry that with them in case complications occur while they are gone. Don't forget about teaching about prevention infection. So no live plants, no live fresh fruits and veggies, good oral care, soft toothbrushes. If they're old enough to shave, electric shaving equipment, good cleaning and hygiene. Avoiding people that are ill. They can't get live vaccines while they're getting their treatments. So one childhood illness that they are very high risk for is chickenpox. So we want to make sure that they don't get that because it could be potentially deadly to these kids. We don't give rectal temps. We shouldn't be doing rectal temps anymore, but we definitely don't want to be doing rectal temps in our patients with cancer due to fissures. And they may be put on some sort of preventative antibiotic to help promote or to help ward off pneumocystic pneumonia. Feel free to make notes and bring questions to class the next time I see you if you have any clarification needed. Thank you.